Welcome and thank you for joining us for the virtual Health Talk, Cancer Screening 101, Understanding Breast, Colorectal, and Lung Cancer Screening Guidelines. I'm health journalist Pam Giganti, and I will be your moderator for this evening's webinar presented by Sylvester Comprehensive Cancer Center, part of the University of Miami Health System and the Miller School of Medicine. We are happy to share that 5 years after being awarded the prestigious National Cancer Institute designation, Sylvester Comprehensive Cancer Center has earned it again, achieving an outstanding score. As one of the 72 NCI designated cancer centers, Sylvester is in the top 4% of all cancer centers in the nation, a lot to be proud of. To learn more on why this matters, please visit sylvester.org. Tonight, we will hear from esteemed Sylvester experts Dr. Monica Yepes, Dr. David Goldberg, and Dr. Coral Olazagasti. They will explore the following topics: breast cancer screening, understanding the importance, methods, and timing of breast cancer screening, the ins and outs of colorectal cancer screening, current knowledge, advancements, and future directions of lung cancer screening. As a reminder, a Q&A session will take place at the end of this presentation to answer any of your questions. Please use the Q&A feature at the bottom of your Zoom screen to enter your questions, and we'll prepare them for experts to address. Now it is my pleasure to introduce our first speaker this evening, Dr. Monica Yepes. She is a breast radiologist and associate director of breast imaging services at Sylvester Comprehensive Cancer Center and a professor of radiology at the University of Miami Miller School of Medicine. As the division associate director, she has overseen the expansion of breast imaging services to Sylvester satellite locations in Deerfield Beach, Plantation, in Doral, Solemia, and at the Lennar Foundation Medical Center, as well as at Jackson Memorial Hospital, bringing state-of-the-art imaging, including digital breast, tomosynthesis, and contrast-enhanced mammography to much of South Florida. Dr. Yepes, welcome. It is great to have you with us this evening.
Thank you so much. It's a pleasure and an honor to be here with all of you today. So without further ado, let's go ahead and get started. Oh boy, of course, here it is. Okay, does everybody see my screen?
Yes, we see it, doctor. Thank you so much.
Okay. All right. So as we discussed, we're going to be talking about breast cancer screening, the why, the when, and the how. Hopefully by the end of this talk, you'll be very knowledgeable about all of this. Okay, so what are the objectives of our talk today? So first of all, we're going to discuss the importance of early cancer detection. We're going to discuss the screening guidelines and recommendations. We will discuss personalized screening strategies according to risk factors and breast density for different patients. We're going to touch on screening and pregnancy, which may be something you don't know about, and very briefly touch on breast cancer in men. So why is breast cancer so important? So it is the most common cancer in women, accounting for 30% of all the cancers that occur in females. And unfortunately, it is the second most common cause of death due to cancer after lung cancer. So why do we screen? We want to reduce deaths caused by breast cancer. And how do we do this? Through early detection when treatment is more effective and less harmful. So what happened before we had breast cancer screening? We were only detecting cancers on clinical inspection. And how do we find a cancer on clinical inspection? It's usually going to be a lump. And unfortunately, by the time we find a lump, it tends to be larger. So usually about 1 centimeter in size. And then that's about 1 inch in size, which makes it much more likely for that cancer to have spread to other areas of the body. Other signs of breast cancer can be changes in the skin, such as retraction, dimpling, discoloration, changes in the nipple, such as nipple inversion, and bloody discharge. So once we started screening, we were able to find these very small cancers before they were even palpable, and hopefully what we encounter is that these cancers should be approximately 0.5 centimeter by the time we diagnose them instead of a full inch. Now, the risk of that cancer spreading to lymph nodes, the lymph nodes which are in the axilla or armpit, and other sites of the body increase with the size of the tumor. So the smaller the tumor, the greater the opportunity we have for timely and effective treatment. So what is the evidence for this? So when we talk about evidence, our gold standard for evidence are the randomized control trials. What does that mean? We take two groups of patients who have similar characteristics, and one of the groups gets subjected to an intervention, in this case screening, and the other doesn't. And then years after, we try to identify which group does better. So the randomized control trials that were done in the 40s, in the 1980s and 90s, approximately 40 years ago, demonstrated without doubt that early detection decreased mortality anywhere between 50 and 32%, depending upon the age of the patient and the type of study. The greater the patient age, the greater the reduction in mortality. Observational trials, which are what happens in countries, for example, when there are organized screening programs and some parts of the country do screening and others don't, showed that breast cancer mortality also reduced in those groups that were subjected to screening. Again, similar statistics, anywhere between 31 and 40%. So this is a pretty busy slide, but I'm going to direct you to the pink curve, of course, pink for breast. You will probably look at lung and colon in the next talks. And look at what happens to mortality. It comes pretty even. And then all of a sudden, in about the 1990s, it starts to drop. So guess what happened? We started screening. So screening alone caused a very dramatic decrease in mortality. So that was the first goal of screening, to reduce mortality. But what are secondary goals? We want to minimize the harm that advanced tumors produce for treatment, right? So the smaller the tumor, the more conservative our treatment can be. We can do a lumpectomy instead of having to do a mastectomy. We can do less aggressive or no chemotherapy. With what this translates into is reduction of loss of productive time for patients, increase in quality of life, and reduced expenses from their treatment. So when should we screen? So if you're a little confused, you're not the only one, because we hear about this all the time and it changes from year to year. But I'm going to make it very simple for you. The American College of Radiology and the Society of Breast Imaging and most of the clinical colleges recommend that we begin at age 40, screen yearly, and this is how we maximize mortality reduction. All the other guidelines that you hear about are not really adhering to the evidence that we have. And this is what we at Sylvester, and this is what all of our academic institutions recommend. So let's go over that again. Begin at 40 yearly, and this is how we're going to maximize the mortality reduction benefit. So you might ask, is beginning at 40 too early? Because that has been part of the controversy. Well, let's look at the facts. 12% of all breast cancers occur in that age group, in the 40s. 17% of all breast cancers happen in this age group because these cancers tend to be more aggressive, which means we need to find them at an earlier stage. And something that has just come to light is that there's been a 2% annual increase in the number of invasive breast cancers between the years of 2015 and 2019 in this age group. And this is why some of the guidelines that had gone back had said not to begin at 40 have also begun to say we should begin at 40 now. So start at 40. And how often? A little confused about that. There has been a lot of news about this as well. But again, if you were paying attention, yearly. So this is the recommendation that we make, yearly starting at age 40. Now, how should we screen? So mammography has been our most important tool for screening. All of the studies that we've talked about are based on the results of analog 2D mammography, which is the most simple kind of mammography. And even with that, we were getting these fantastic results. Now we have all these other new technologies, such as digital mammography, tomosynthesis, or 3D mammography. And all of this has only helped to, increase our early cancer detection. We have additional screening tools such as ultrasound, MRI, and contrast-enhanced mammography, which we're going to touch on briefly. So how do we choose how to screen? Well, the first thing we do is we look at risk factors and we look at the breast density. So when you come in for your mammogram, you're going to be asked a lot of questions about your family history, your ethnicity, your weight and height, because obesity leads to a higher risk for breast cancer. Age at first menstrual cycle and menopause, because the longer your body is exposed to hormones, the greater the risk. Age at first birth, number of children, and lactation. And other things such as history of biopsies, types of biopsies, the use of any type of hormones such as contraceptives. And we're going to look at breast density, whether it's fatty or dense, and we'll touch on that in a second. So what the American College of Radiology is recommending that all women should have an understanding of their risk for breast cancer as early as age 25. Why? Because if you are at high risk, we need to start screening earlier than age 40. So we need to know before you get to age 40. And this is especially true for women of African and Ashkenazi Jewish descent to see if they need early screening. And why in these patient populations? Because they have a higher incidence of BRCA mutations or breast cancer gene mutations, and they also have a higher incidence of early cancers. Now, particularly interesting and only more recently known is the effect on women of African descent. Unfortunately, they have a higher incidence of aggressive cancers. They're called triple-negative breast cancers, which tend to present at a younger age and which have an increased breast cancer mortality. Now, other factors that contribute to that in women of African descent, of course, is disparities, more difficult access to healthcare, and other factors. But this is why we need them to have an understanding of their risk factors. So once we've done that risk assessment, we kind of put patients into three groups: average risk, high risk, and then an intermediate risk. And so women who are at a very high risk, such as those who have genetic mutations, and you may have heard of the BRCA1 and 2, there are several others, or who have a very strong family history, need to begin screening as early as ages 30 or 25 even. And so it depends on their family history. So mammograms may begin between 30 and 40, and we may need to begin with annual MRIs as early as age 25. So this is an MRI, which we give contrast, and contrast accumulates within the tumors, making it much easier for us to see them. Now, we talked about breast density. What does that mean? Breasts are made up of fat and glandular tissue. The glandular tissue is what makes and carries milk. So the fattier the breast, the darker it is. So finding this little white cancer in this dark breast is much easier than finding this cancer in this dense breast. And this is so breast density works in two ways. One, it obscures cancers, and two, it increases the risk for cancer because there are more glandular structures. So what can we do for these patients? So an absolute must is to use tomosynthesis or 3D mammography. We can detect up to 3 to 4 per 1,000 more cancers than if we just use mammography alone. What tomosynthesis does is it peels away layers of the tissue so that we can find this cancer more easily. We have ultrasound, which we can recommend for patients of normal risk, and MRI or contrast-enhanced mammography, which, as we said, use contrast, which deposits in tumors so that we can find them more easily. Now, briefly, we're going to talk about screening and pregnancy. You may have thought that if you're pregnant, you can't screen. Well, unfortunately, up to 3% of all breast cancers occur in patients around pregnancy. That means during pregnancy or while they're lactating. And because women are now delaying pregnancy until later ages and prolonging lactation, we were finding very advanced cancers in these patients. So we sat down and looked at the actual risk of radiation on a mammogram, and it's extremely low. It's less than 1/1000th of the dose that can actually harm the fetus. And if on top of that, you place a lead apron, you further reduce that dose by 2 to 7 times. So it's absolutely safe to do a mammogram during screening, and we recommend that you should. So you should continue doing screening according to your age and risk factors, as we mentioned before. And if you're planning to become pregnant, and you should be screened before you do so, because it'll be easier to deal with a cancer before you're pregnant than while you're pregnant. What is contraindicated is MRI, because gadolinium is not approved during pregnancy. And finally, male breast cancers, they constitute 2 to 9 per thousand of all cancers. They're more likely in patients who have genetic mutations such as BRCA1 and 2. Current recommendations are that males who have these mutations should begin screening at age 35 and should have annual mammograms at age 50 or 10 years prior to any diagnosis of cancer in their family. There is no screening recommendation for men of average risk. So to conclude, screening reduces breast cancer mortality in all age groups. Some women may need to personalize their screening, as we mentioned, according to their risk factors or breast density. Women need to be aware of their risk factors as early as age 25 in case they need to start early screening, they can. And pregnancy is not a contraindication to screening mammography. And finally, males may get breast cancer. So at Sylvester, we do use the necessary tools to assess your risk and breast characteristics so that we can personalize your screening. Thank you.
Thank you so much, Dr. Yeps. A lot of great information there for women because it can be very confusing. So we really appreciate that very thorough presentation, especially about starting to get that mammogram yearly at age 40, unless you're considered high risk. So we appreciate that. Thank you so much. And we, of course, invite you to explore your breast cancer risk at sylvestercancerprevention.com. All right now I am pleased to introduce our next panelist, Dr. David Goldberg. He is a gastroenterologist at Sylvester Comprehensive Cancer Center, associate professor of medicine in the Division of Digestive Health and Liver Diseases, and associate professor of public health sciences at the University of Miami Miller School of Medicine, with expertise in liver transplantation, solid organ donors, and liver cirrhosis. And much of what Dr. Goldberg's clinical and research interests are include chronic and end-stage liver disease, as well as transplant hepatology. Additionally, he is the Associate Program Director for the GI and Hepatology Fellowship Program. Dr. Goldberg, welcome.
Thank you very much for the introduction. So I am a gastroenterologist and a hepatologist, meaning I see people with both GI disease and liver disease. So the one disclosure is I'm a practicing gastroenterologist and hepatologist who routinely performs screening colonoscopies. Despite my youthful appearance, I actually had my screening colonoscopy in May when I turned 45, and what shocks many people is that I had it without sedation, and that's something that we can discuss in the Q&A session. So what is colorectal cancer? So it is the cancer of the large intestine or rectum. It typically starts as polyps, which can then advance to dysplasia, sort of abnormal cells, and eventually cancer. This is sort of the sequence. And what's important here, and again, obviously not for people to know this entire sequence, but this is a process that unless someone has some genetic predisposition, takes about 10 to 15 years to go from normal tissue to a polyp, which I almost tell people is like a mole, and then to cancer. So we can catch this early before it even actually becomes a cancer. And again, for those who are not aware, this is what your colon looks like and where it is located in your body. So what is the epidemiology of colorectal cancer? So excluding skin cancer, it is the third most common cancer in the US. The predictions are that in 2024, there'll be over 100,000 new cases of colon cancer and about 46,000 cases of rectal cancer. The lifetime risk is about 1 in 23 for men, 1 in 25 for women. And again, it is very common. It is a common cause of not just cancer, but cancer death. And it is something that we can prevent. In 2024, it's predicted there will be more than 50,000 people in the US that die for colorectal cancer. Again, stage of diagnosis matters like many cancers. When caught early, the 5-year survival exceeds 90%, but when diagnosed late, when it's metastasized beyond the colon, outcomes are far worse, which is why early detection is critical. So there are a lot of different societies that have different recommendations, and I think it's important to understand what they are and sort of why they may differ. And I will say, while I do follow the U.S. Multi-Society Task Force on Colorectal Cancer, the 3 acronyms there, the American College of Gastroenterology, the American Gastroenterology Association, and the American Society of Gastroenterological Endoscopists. So clearly there is an inherent conflict of interest when all 3 societies are made up of physicians who do obviously benefit from performing colonoscopies. That being said, I do think they are fairly fair guidelines. So the recommendations are to screening starting at age 45 for average risk. This has changed over the last 5 to 10 years, and there still is some debate about this, but 45 is the recommendation. We rate the sort of in our society sort of the tier of screening tests, and I think one of the things that I'll say later on is what people say is the best test is the one you get. So if you may not want to get a tier 1 test but you'll get a tier 2, that's better than nothing. So tier 1 is a colonoscopy every 10 years, or a fit test, which I'll explain more, every year. Tier 2 is a flexible sigmoidoscopy, a multi-targeted stool DNA or CT colonography, and tier 3 is a capsule colonoscopy that we really don't do in the US. Now, the US Preventive Services Task Force is slightly different. They still recommend starting at age 50, and the recommendation to go from 50 to 45 is because there's been an increase in colorectal cancer in younger people, but these are not based on the highest level of evidence that was discussed in the prior talk, is based really on statistical modeling tests. They say that first line is a colonoscopy, a flexible sigmoidoscopy every 5 years, or every 10 years with a fit test, or stool testing annually. So there are a lot of options. And again, no one test is best, but it's a matter of which one you have done. Now, what are the goals of colorectal cancer screening? Obviously, we want to prevent deaths from colorectal cancer. We want to prevent morbidity from colorectal cancer. So even if you have cancer and you're not going to die from it, there's surgery, which is obviously quite invasive, and chemotherapy, or prevent the development from colorectal cancer. And that is really important when thinking about the different screening options. So, how do you prevent morbidity and mortality from colorectal cancer? You want to diagnose it at an earlier stage. So, before it spreads outside the colon, this impacts survival and impacts the need for chemotherapy. If you diagnose it at an early stage when it's within the colon, you could do surgery and avoid the need for chemotherapy. If you want to do before it's large, obviously, the need for surgery. Now, the option though also is to diagnose it before cancer develops. So, how can you diagnose it? I'll get into the different methods, colorectal cancer screening. So, there are blood-based methods to diagnose it. Now, there's stool and blood-based testing, which both will diagnose cancer at an earlier stage. This won't diagnose it before it becomes cancer, but diagnose it earlier to prevent morbidity and mortality. Now, these tests, and I'll show some numbers, which I don't expect people to, absorb, but it's good at diagnosing cancer, but it's not good at diagnosing precancerous lesions. And all of these tests still require a colonoscopy if positive. They're not diagnostic for colon cancer. So a new test that was recently approved this year is a cell-free DNA. This is a blood test. Again, the performance is 83% sensitivity, meaning if you take 100 patients with colon cancer, they have confirmed cancer, you test 100 of them, 83 will test positive, which you could say is good, but 17 will test falsely negative, meaning they have colon cancer, but it won't be detected. The specificity for advanced neoplasia, meaning if you take 100 people without advanced neoplasia, so you have 100 people that have totally normal colons, 10 of them will falsely test positive, being told that they have advanced neoplasia, a very advanced precancerous lesion, which obviously will lead to a lot of anxiety. And a 13% sensitivity. What this means is this blood test is not very good for detecting polyps that are not just, 1 or 2 millimeter polyps. Stool-based testing, so the FIT test that I recommend, that I mentioned before, is to test to look for hidden occult blood using antibodies against human hemoglobin. These tests, again, if you compare this to the numbers before, maybe not quite as good as the blood testing, but again, we recommend this every year. And similar to the other blood and stool tests, is not very good for detecting polyps that are very advanced. So it's pretty good for cancer, not great, not very good for polyps. Cologuard, which is a stool sample. If anyone watches SNL, I think it was a year or two ago, there was a skit with Woody Harrelson and the Cologuard boxes that he was, having hallucinations about. This is a sample. Again, you could do this at home, and there's two parts. It's looking for proteins that may be shed by cancers or polyps, and also that fit, that blood testing. This is better, but again, it's good for cancer, not great for advanced polyps. And again, you have to do this really every 1 to 2 years for it to be useful. What about colonoscopy or sigmoidoscopy? So these are tests that allow for direct imaging of the colon to diagnose cancer. diagnose and remove polyps. Now, what's the similarities and differences? So they both require clear liquids the day before. And again, for anyone who's scheduled for colonoscopy, we mean the entire day before. If you're scheduled for 3 o'clock on a Friday, that means clear liquids the whole day Thursday. They both, in theory, will require sedation, but as I mentioned, not always. I had mine without sedation. They both have risks of bleeding and perforation. Now, what are the differences though? So the prep is much easier with a sigmoidoscopy. We use an enema versus a full gallon or two of liquid. The follow-up, so if you have a flexible sigmoidoscopy and you have polyps, then you have to get a colonoscopy because it's only looking at half of the colon. And a colonoscopy, again, it depends. If you have no polyps, it's 10 years. If you have polyps, it's several years, depending on the type and number. Now, not going to get into all of the data, but just to show it, that flexible sigmoidoscopy has been tested in a randomized control trial. It reduces colorectal cancer incidence and mortality, which is what we're going for. Now, there's actually only been one large randomized control trial of colonoscopy screening. And this is, again, the gold standard of data. What was important, though, is that this was not a study of everyone getting a colonoscopy or not. It was a study in Europe of people getting an invitation to receive a colonoscopy for its usual care. What the study found is that those who were invited to get a colonoscopy had a lower risk of colorectal cancer at 10 years. And the risk of death, though, was not statistically significant. So there was a lot of lay press and, Twitter or X people that were sort of naysayers of colonoscopy saying, look, colonoscopies don't work. But again, the randomization was getting the invitation. If you actually look at those people who got a colonoscopy, they actually had better outcomes than those who had a flexible sigmoidoscopy. So really the conclusion of this is that colonoscopy works when it's done. If you invite someone to get a colonoscopy and they don't get it, the colonoscopy is not going to work. So what do I tell patients and friends? And my wife makes fun of me because when my friend turns 45, I send them a birthday text and a reminder to get a colonoscopy. So I tell them the best test is the one you will get. My preference and my personal choice is a colonoscopy, which I had, but again, it's what you will have. What about someone who's a high risk of anesthesia? They have heart disease or lung disease, or they, can't get sedated. Well, they can get a stool-based testing annually, or they can get an unsedated colonoscopy. And it's interesting because we discuss, childbirth without anesthesia quite regularly. People talk about it, but we don't discuss unsedated colonoscopy. Most gastroenterologists I know at Sylvester U Health would be willing to do a colonoscopy without sedation, but of course you have to ask. Now, what about someone with a limited lifespan? And this question came up about age. It's not just about age, it's age or medical comorbidities. Obviously, if we take out a 2 millimeter polyp in someone that has a 5-year lifespan, we're not preventing any bad outcomes. If someone is going to be diagnosed with cancer, but they can't survive surgery due to all their medical comorbidities, are we really helping them? And those are the things that we consider. 75 has been, floated as the age that you consider stopping colonoscopy. But again, I think 75 is a moving target. So when is follow-up needed if I have a polyp? So this is the recommendations and this is what the guidelines are. But now not everyone follows this because these are all based on retrospective studies. Some of these numbers, I don't want to say they're made up, but they're scientifically made up and the numbers are moving targets. When I was a fellow 10 years ago, we said if you have one polyp, it's 5 years. Now we say 7 to 10 years, which is why I bring up we are now at Sylvester part of a multi-center study sponsored by the NIH to actually understand what is the best interval for colonoscopy screening. So what we're actually looking at is taking patients between the ages of 50 and 70 with 1 or 2 small polyps and saying, will you be randomized to get a colonoscopy in 5 years and then a second one 5 years after that versus 10 years to see at the end of this, what is the difference in the risk of cancer? Because maybe, and again, this is probably, taboo to say as a gastroenterologist, we might be doing too many colonoscopies. And if we have someone who has one polyp, we should be telling them 10 years and not 7 years. And again, I put information up here. If anyone here listening is between the ages of 50 and 70 and has had a colonoscopy in the last 4 years with 1 or 2 small polyps, it doesn't have to have been to Miami. Please contact my research coordinator and we could see if you might be eligible for this study. So in conclusion, colon cancer screening is important to detect precancerous polyps or early stage cancer. Survival is strongly tied to stage of diagnosis, and the best screening test is the one the patient gets. Thank you very much.
Dr. Goldberg, thank you so much. Great information. I love how you send your friends a birthday card at 45 reminding them to get their colonoscopy. It reminds me of dentists who give out toothbrushes at Halloween. But very important. Thank you so much. What a great and informative presentation. So we invite you to explore your colorectal cancer risk and screening options at sylvestercancerprevention.com. And now I am pleased to introduce our next panelist, Dr. Coral Olazagasti. She is a thoracic medical oncologist and assistant professor of clinical medical oncology at Sylvester Comprehensive Cancer Center. Dr. Olazagasti developed an interest in lung cancer screening early on in her career with hopes to prevent and detect lung cancer in its early stages. Being a Latina physician, she is personally interested in ethnic and racial disparities in the medical field and investigates the inequities and the barriers that minority patients face in healthcare. She hopes to continue to expand her research to help close the gap for minority populations. Dr. Olagasti, welcome.
Thank you for having me, and good evening, everyone. I'm going to be sharing my screen now. So today I want to talk about this topic, which is very near and dear to my heart. This is my focus of research. And my title is titled Lung Cancer Screening, What We Know, Where We Are, and Ways to Go. And I just want to start by saying that lung cancer remains the leading cause of cancer death worldwide. And I think this is an information that a lot of people are not aware of, and it's still true to this day. And I think this is why it's so important to talk about it in a night like tonight. So we can see here that lung cancer is responsible for 20% of the cancer deaths in both men and women. And those are much higher numbers compared to 11% of prostate cancer in men and 9% of colorectal, and in women, 15% in breast and 8% in colorectal. Not that they're not important, but it's interesting because lung cancer is responsible for so many deaths, yet lung cancer screening has not had the movement that other types of cancer have had. And so when we look about lung cancer, like other types of cancer, the 5-year survivals are directly related to the staging and diagnosis. Unfortunately, still to this day, almost 50% of all the patients that are diagnosed with lung cancer are diagnosed at stage 4 disease. This is the most advanced staging. And therefore, that translates into poor survival rates. So only 6 out of 100 patients will be alive of 5 years when they're diagnosed at stage 4. But when we look about cancers being diagnosed at other stages, for example, here in yellow-green, for the patients that are diagnosed with cancer that's local to the lungs and only spread to lymph nodes, the overall survival at 5 years improves significantly to 33%. And those numbers are even higher for those that are diagnosed with cancer only localized to the lungs, confined to that primary site, when the survival rates at 5 years go up to 60%, so over half of the patients. This is why early detection of lung cancer is so important. Now, in general, lung cancer 5-year survival rates have minimally improved over the past few years. We can see that in 2005, it was 16%, and now as of 2023, it's only 26%. Whereas other types of cancer, they have gone such great breakthroughs, and this is mainly because of screening. Now, when we look about Florida, because obviously that's our point of interest, we know that the survival rates are just a tad little bit higher compared to the national rates, but it's still not quite good enough. Now, let's look about potential disparities among Latino individuals in Florida. Unfortunately, we see here that Latino patients are less likely to have an early diagnosis compared to white individuals. Nevertheless, importantly, they have higher rates of surgical interventions compared to non-Hispanic whites. And so what causes lung cancer? We know that cigarette smoking is related to higher rates of lung cancer. It increases your risk for over 20%, over 20 times, sorry. But there's other also exposures such as radon, asbestos, environmental exposures, genetic, meaning a family history of lung cancer, other diseases, and prior radiation. Unfortunately, we have seen in recent years an increase on the trends of lung cancer in patients that have never ever smoked and those that are on the younger population, meaning less than 50 years of age. Now, because other cancer types have done so great with screening, investigators in the 1970s started to inquire about potential screening modalities, and they created the Johns Hopkins and Memorial Sloan Kettering Lung Study, evaluating the role of chest X-ray for lung cancer screening. Unfortunately, this was a negative trial, but they persisted and persisted and persisted, and it wasn't until the 2000s where they used a low-dose CT scan as a screening modality where they found very impressive results. And this led to a study that was then conducted and replicated in Europe and other parts of the world. Now, these studies found that with low-dose CT as a screening modality, that the patients that are diagnosed with lung cancer, they have 20% less mortality than those that are diagnosed without this technology. And this is because obviously patients that are diagnosed with a low-dose CT for screening are diagnosed at earlier stages compared to those that are not screened. Now, there's a need of 320 persons that need to undergo a low-dose CT scan to prevent one death from lung cancer. So since the studies came out, the NCCN guidelines approved lung cancer screening for patients that they consider at high risk. And those they defined as patients between the ages of 55 to 74 that were current smokers or former smokers that had quit within 15 years, and those that had more than 35-year history of smoking. They had another category B recommendation with a 25-year history of smoking if the patients had an additional risk factors. And they defined those as a family history of cancer, of lung cancer, a personal history of malignancy, history of COPD or pulmonary fibrosis, or secondhand smoke or chemical asbestos, chemical exposures. On the other hand, the USPSTF recommended screening in 2013 for patients that are between the ages of 55 to 80, current smokers or former smokers that quit within 15 years, and those with a 35-year history of smoking or more. Unfortunately, these numbers and this criteria was taken from the National Lung Screening Trial, where over 90% of the participants were white. And so they found that by using this very strict criteria, we were missing the opportunity to screen minority individuals, particularly Black patients. And so what did they do? In 2021, the USPSTF decided to update their screening guidelines and lower the start age to 50 and lower the pack years to 20 or greater in hopes of increasing the eligibility and reaching more minority individuals at high risk for lung cancer. Now we know the screening guidelines, are they being implemented? Unfortunately, the answer is no. In 2015, when they were approved, the rates of screening in eligible participants was only 4.5%. And guess what the screening was in 2023 for eligible participants? 4.5%. So even though these rates have improved a little bit in recent years, the numbers came right back down this past year. And there's rates as low as 1% for eligible participants in California and Wyoming. The state that is doing the best job is Massachusetts, screening almost 20% of the patients that meet the criteria for high risk for lung cancer. Now you might wonder, how are we doing in Florida? Only 2.4% of the population that is eligible or meet criteria is getting screening. That is a potential misdiagnosis and missed opportunity in basically 97.6% of the patients here in Florida. Now, what's happening? What are the barriers? What are the barriers from the physician's standpoint? Because physicians are the ones that need really to talk to the patients and refer patients for screening. Some of the barriers are that they're not aware of Medicare and Medicaid coverage of the scans. Many of them really don't know what to do with the findings. Sometimes people have some pulmonary nodules and they're not quite clear how to follow them, or they're already burdened by too many responsibilities. There can be false positives, meaning that patients undergo procedures and they end up being negative, and it's a high risk for invasive procedures. Some people are concerned for radiation exposures, even though the radiation risk is very, very low. That's why it's called low-dose CT. And some physicians are just unaware that the guidelines exist. Now, many of the apprehension is, oh, but so much false positive. Look, almost 20 to 25% patients have a false positive rate. Yes, but that leads to only 0.4 to 2.4% of false positive biopsy rates. And that's way lower than screening mammogram. And I'm not saying here, do not do mammogram. Keep doing a great job with your mammograms. But what are we doing that our numbers are not close to those numbers of mammography and colonoscopy? We need to do better. Now, what are the barriers to screening from the patient's perspective? The fear of cancer diagnosis, the fear of potential cancer treatment, the fear of potential radiation exposure, and more than anything, the stigma and the shame around smoking. We're trying to really create a conscious approach into not blaming the patients for smoking and making sure that we don't provoke judgment in the patients. We know that there's stigma and shame, that we're not embarrassed of you. You should not be embarrassed of yourself. God forbid you have cancer. You did not cause this on yourself. And we really are trying to turn the page in this perception that people have and that the world have, that it's unfortunately leading to patients being afraid of seeking help and seeking screening. Now, in 2011, Sylvester became the first centralized screening program in South Florida. So they're approved by the American College of Radiology, and they're doing a great job screening. And so they compared, and this is a little bit of an older study, but they compare the patients, the cohort of patients where they detected lung cancer compared to the large study, the National Lung Screening Trial, and they found a greater lung cancer detection rate of 3.3% with low dose CT compared to only 1.1% in the big trial. And the majority of these patients were only stage 1 and stage 2, which means there's potential for resection, which means they'll probably be alive at 5 years and beyond. Now, what do we do at Sylvester Lung Cancer Screening Program? It's ran by the amazing Nicole Gay. She's an APRN. And so she has a criteria with a shared decision-making. And what does the shared decision-making entails? So they discuss benefits. What are the benefits to screening? It's early detection for lung cancer, high chances of cure. What are the potential harm from screening? Patients need to know that there might be a possibility of false positive, that there might be some more invasive procedures or follow-up studies that you might have, and there's a potential for radiation exposure. Patients must be committed to at least entertain tobacco cessation. They receive a tobacco cessation referral, and they must really have willingness to quit. And they must be committed to screening, because this is not a one-time deal and a one-time study. This is an annual study that you need to do. And it might entail some follow-up studies depending on what the scans show. And then we hope that patients are committed to that as well. And so this is the screening workflow. The patients are referred to the screening program. The nurse navigator pre-screens the patients. She sees them in the lung cancer screening program. She orders the CT, which is read by a certified radiologist. If there's suspicious findings, then she sends the recommendations to the thoracic surgery, pulmonology, or pulmonary clinic. If there's no suspicious findings, then we follow the recommendations according to the lung RATS criteria, which is depending on the size of the nodule and the shape of the nodule. Some people need to repeat the imaging in 3 months. Some people need a PET scan follow-up, and some people just need annual studies. Now, what are the advantages for screening? The dedicated nurse navigators that's with you, that she calls you, she's making sure that nothing falls through the cracks, and she is making sure that you get your annual scan. There's a lung cancer screening module, and we have a pulmonary nodules to just follow up the specific findings. This reduces the burden from the PCPs, which are already overworked and underpaid, but that's a different conversation. And there's a referral to a multi-D program where if you need a follow-up with a medical oncologist, a pulmonologist, a thoracic surgeon, you have the care right here at Sylvester. And so I just encourage everyone, if you meet criteria, or if there's any family members that you know that smoke that might meet criteria, encourage them to come seek an evaluation. You can do self-referral or talk to your PCP, because really, like, early detection really saves lives. Thank you.
Doctor, that was wonderful. Thank you so much for that presentation. There is a lot that people don't know about lung cancer and screening. So thank you so much for that. It was really eye-opening. And we certainly invite you to explore your lung cancer risk and understand your screening options by visiting sylvesterlungscreening.com, or Here's the number. You can call 305-689-5864. All right, thank you, doctors. Great presentations. We're now going to launch into our Q&A session so that our experts can field your questions. And we are going to start with Dr. Goldberg. We have a question for you, doctor. Somebody wrote in and said, my sister, who's 47 years old, was just diagnosed with rectal cancer. I am 43 years old. Should I get screened?
Right. So, I had mentioned sort of when we stop screening, but not necessarily when we start in these settings. So if someone has a first degree, sibling, parent, unfortunately, I guess a child, relative with colorectal cancer before the age of 65, we recommend that we start at age 40 or 10 years from when they were diagnosed, whatever is earlier. So, if someone was diagnosed at 40, we would start screening someone at 30. So in this setting, your sister was 47, you were 43, you absolutely should get screened. And if you get screened and your health insurance, again, knock on wood, should absolutely cover this, you will be getting them every 5 years because you had a first degree relative under the age of 65. If a first degree relative is older, we start the first one younger, but then we still go to every 10 years. So my grandfather had it, my dad had it, his colonoscopy younger, but then went to every 10 years.
All right, doctor, thank you so much. That was really informative. Dr. Olazagasti, we know that smoking increases lung cancer risk. You mentioned that in your report. If someone quit smoking, let's say 20 to 30 years ago, are they still considered at high risk for lung cancer?
So that's a great question because right now, the answer is yes, in short. Unfortunately, right now, the criteria that is approved only includes those that have quit within 15 years. And this is some of the things that investigators like me are urging organizations to change these guidelines. These guidelines are too strict. Who says that 15 years is the right approach? Because sometimes people, even beyond that, we know that the risk lowers the more time that passes that you have quit, but there is risk nonetheless. And we strongly believe that the guidelines eventually are going to remove that limitation and just approve screening for everyone within an age bracket that as former smoker that quit whenever, as long as you have the 20-pack year history of more. That history itself should carry more weight than the time that you quit. And the American Cancer Society is actually already moving towards that screening guidelines. We just need now to the USPSTF because that's what the insurance companies and Medicare and Medicaid reimburse after. And so, yes, great question.
Okay, so what we're hearing is yes, you're considered high risk, you should get screened. Correct?
Yes, but it might not be reimbursed because it's still not approved in the guidelines. So,
Gotcha.
but it's important to bring it up to your PCP. Perhaps there's a leeway that can be done.
Excellent. All right, doctor, thank you. Dr. Yepes, this is for you. Can you speak briefly to the early symptoms of breast cancer? Can screening options like routine mammograms detect breast cancer before any symptoms occur? You're not feeling anything necessarily, right?
Correct. The idea is that we should detect it before it's palpable or something that you can feel. But other symptoms, like I mentioned in the talk, would be changes in the skin, such as retraction or dimpling of the skin, discoloration, changes in the nipple, for example, nipple inversion or retraction, nipple discharge that is not milky, and obviously anything that feels like a lump in the axilla or armpit, as that's where breast cancer can spread to.
Okay, thank you. Dr. Goldberg, is there an age at which it's no longer recommended and or safe to have a colonoscopy? Like, do you get to a certain age where your doctor says, you know what, you're, I don't know, 75, 80, you don't need them anymore? Speak to that.
So, it's not that we can't do colonoscopy if someone's older. Obviously, it's really their medical comorbidities, but it's that it depends on, that what is your lifespan, because the goal is really to identify polyps. 75 is the age that we historically have said, although it's really dependent on what your medical comorbidities are. For 75, I think, age is obviously evolving, in terms of what you can do when you're older. My parents both stopped at 75, but they had had several normal colonoscopies. I just had a patient recently, it was their first time getting one at 77. They had no medical problems. That was totally reasonable because they've never had one before. They had few medical comorbidities. But it also really depends on how sick you are. If you're 50 years old, but you have end stage heart disease and lung disease and metastatic lung cancer, obviously we wouldn't do a screening colonoscopy.
Yeah, I think it's important for people to remember, and you can speak to this as well, doctor, that there's your chronological age and then there's your biological age. Some people at 75 might be healthier than somebody who's 55, right?
Exactly.
Yeah. Thank you, doctor. Dr. Yepes, is there a concern for hormonal changes due to menopause and breast cancer? On self-examination, how can you tell the difference between normal hormonal changes and possible changes due to cancer?
Okay, so that's a great question. So normal hormonal changes are usually going to change with the menstrual cycle. So sometimes you might feel lumpy and tender right before your period or somewhere in the middle of the cycle. So we don't recommend that you palpate, that you examine yourself right before your menstrual cycle or in the middle. The best time to examine the breast is usually right after the period is done. So for example, if your menstrual cycle started on Monday and ended on Friday, you might examine your breast on Saturday, okay? Because that's when it's going to be less turgent and you're going to find less lumps. So those are the normal cycles. Something important is that patients around menopause, perimenopausal, sometimes have flares in the way they feel, their breast feel. They feel more tender, more lumpy. And it's because those hormones are doing like this up and down right before they go away completely. And just to be aware of that. Now, in terms of menopause, after menopause, patients who take hormones are at a slightly higher risk of developing breast cancer. Now, that doesn't mean that you should never take hormones. Like everything in medicine, there's no free lunch. You kind of have to weigh the balance of your advantages versus disadvantages, and hormones are helpful for other things, heart health, bone health. So it's a difficult balance, and it's something that every woman should discuss with their gynecologist, okay? Again, that exposure to hormones past menopause can slightly increase the risk of breast cancer.
And I would imagine too, doctor, that there are patients who are, you talked about in your presentation, fatty breasts and dense breasts. I guess the women with dense breasts, it's got to be hard sometimes, right? To know what you're feeling.
Exactly. So some women have naturally lumpy breast tissue, and that's why we think it's important that you know your breast tissue. So if you know how lumpy, if you know your normal lumps and bumps, you will be better able to find something new if it happens. Okay. So again, we recommend examining your breast once a month after the menstrual cycle. And for example, if you don't have a menstrual cycle anymore because of menopause or because you had a hysterectomy, for example, choose a day in the month, like, first day of the month, and always examine yourself on that day.
All right, doctor, thank you. Dr. Olazagasti, is surveillance, care, or lung cancer screening recommended for patients after a lobectomy? And if so, for how long?
Absolutely. So after surgery, you get more frequent scans every 3 to 6 months for the first 3 years. And after 3 years, you get annual scans for screening lifelong.
Okay, so if you have that lobectomy, you're in the system forever, continuously
Correct.
screened.
Correct. Because anyone with a history of cancer once is at risk of getting cancer again. And so for lung cancer, that's a guarantee that you would need at least a once-a-year scan.
Gotcha. Good answer. Dr. Goldberg, are at-home colon cancer screenings a reliable screening method for detecting cancer at its early stages? You talked about them in your presentation. Is there a reason that a physician might prescribe at-home screening over a colonoscopy?
Well, I think oftentimes, it will be because of a person either has a fear of a colonoscopy, they don't want to have a procedure, they don't want to have sedation. And that's, I think, where it really is best. If someone says, I will only get a colonoscopy if there's some test that's positive that triggers it, then an at-home test is great. I think the challenge, though, is the at-home tests really have to be done regularly and are also only good at detecting cancer as well. There are also some populations that maybe A colonoscopy prep is not so easy. So patients on dialysis, who get dialysis 3 times a week, it is a real challenge for them to get to prep. So sometimes those patients will say, do the at-home test and we'll only do the colonoscopy and figure out all the logistics if it's positive.
Gotcha. Dr. Yepes, is there a recommended frequency for breast cancer screening post-lumpectomy?
Great question. So usually 6 months after the lumpectomy, we do a mammogram just to have a baseline after the surgery and treatment. But after that, you would have another one 6 months later to do both breasts. So for example, you had a left lumpectomy in June. So in January, you would have a left mammogram as a baseline. And then if you had your previous bilateral, both breast mammogram in June, then in June you would come again for your yearly. And after that, yearly. So immediately after the surgery, 6 months after, one mammogram, and then just yearly.
Okay. So again, you just continued screening because there's a history there of the cancer, right?
But as Dr. Goldberg mentioned, I mean, we don't screen indefinitely. So it depends on healthcare, the exact same considerations that he discussed. So you need to be healthy enough to be treated for cancer if we find something. So I have a great story of an 84-year-old who came for a screening mammogram, and I saw something abnormal, and I said, well, you've got these abnormal calcifications. And she said, well, even if it is cancer, I'm not going to do anything about it. So if you're not going to do anything about it, don't go looking for it, right? So don't look for what you don't want to know.
Gotcha. Good point. Thank you. And Dr. Olazagasti, are there guidelines for referral and screening at the primary care level? And if so, can you speak to them?
Absolutely. So it's something that your physicians should talk to you about whenever you have your annual wellness visits about any types of screening. They should ask you about smoking and screening, and sometimes in the system you get a flag. Nevertheless, oftentimes there's only so much time that the PCPs have to address many different complaints and many different comorbidities and issues. So it might not be at their forefront. So if you are interested, I encourage anyone to bring it up to their PCPs and saying, like, I heard about lung cancer screening, I'm interested, please refer me, and they should be able to. Or if that's not the case, then there's a way through our webpage that you can enter your information and refer yourself.
Excellent. So if somebody's interested, they need to reach out to Sylvester to reach out to your group in order to see if they can be screened, correct?
So there's the website in the Sylvester Lung Cancer Screening Program. There's the questions and you enter it, and it tells you if you qualify, and if that's the case, you can request a screening through there.
Great. Doctors, thank you both so very much. This was so informative. We're all walking away this evening with great information about being screened for different types of cancers. We really appreciate it. Our program has ended. Thank you to our audience, to our experts, Doctors Monica Yepes, David Goldberg, and Coral Olazagasti for the privilege of their time. We appreciate your participation at today's event. Sylvester Comprehensive Cancer Center is now open in Doral, providing more availability for breast, colorectal, and lung cancer screenings. We invite you to visit uhealthdoral.com for more information. You can call 305-24-DORAL to make an appointment to go there. Please complete our survey to give us feedback and to suggest other topics that would be of interest to you. And we look forward to seeing you again on another webinar. Have a great night, everybody, and stay healthy. Good night.
Night. Thank you.
Good night.